So in interest of time, we'll get started. This afternoon, we are going to be talking about the role of multi-modality imaging in the imaging of pericardial diseases. And I'm going to start off representing the echo view. What is new in pericardial diseases? Nothing much in the last 12 months that we have talked. However, there is something in sense of a consensus document that was put forward by the European Cardiology Society, which I think all fellows should read. It is an exhaustive document looking at all the pericardial diseases and particularly emphasizing the treatment and the roles of imaging modality in each. Needless to say, when you have many techniques available for you to image, what is important is that you tailor each for a specific patient involved. There is no blanket that you do A, B, C, and D in any particular order. So the use of the resources we have to be tailored to the question we are asking, the therapeutic implications, and what it really adds to the basic imaging that we do. Echo plays a very fundamental and basic role, and I'm going to go ahead and start with that. Before I start, I would also like to show that the three modalities that I'm going to be focusing on, or this talk is going to be focusing on, is going to be the echo, the CT, and the CMR. And I'm going to spend most of my time talking on echo, but as we look, this is a table from the ESC guidelines, and you can see that something that we all need to focus and pay attention to is the cost that is involved in imaging. And as you can see, echo being the cheapest, and the cost goes down when you go to CMR. Cost goes up, when you go to CMR. And here are the specific things that we look for in each modality and what information, whether it's morphological, functional, that we get across each one. So when you factor all in, it is very easy to see what would be useful when and what would complement each other. So let's go to next. So pericardial diseases, we know that we are looking at pericarditis, effusions, tamponade, constrictive pericarditis, tumors, and cysts. The thrust of this talk is going to be on pericarditis, pericardial effusions, and the constrictive pericarditis that we see more often. I'm going to leave the pericardial tumors to be followed up by Dr. Nabi in the CMR-CT talk, because I think that is a more robust modality for that imaging. So causes of pericarditis, we know that it's idiopathic, viral. In developing world, bacterial and tuberculosis playing a very large role. Sorry, I went ahead. And then, of course, in hospital settings, we see post-op, of course, connective tissue disorders, radiation play a role. And then, of course, you have malignant tumors, secondary being more common from the lung, the breast, lymphomas, then the primary, and of course, in rare cases, trauma and post-procedural, that is not so rare. So starting with acute pericarditis, the diagnosis is pretty usually clinical. Patient comes in with chest pain. You have a rub. You may have a EKG changes of elevations and ST elevations and PR depressions across the board. And of course, pericardial effusion, which is new or worsening on echo. Then we look for the supportive markers. What the ESC document has done is divided into acute, incessant, recurrent, and chronic. The last three have some relevance in terms of how long you're going to be treating these patients, whether you image them further with CMR, which will it help guide the treatment. The standard treatment has been with NSAIDs, and adding colchicine has now been recommended very strongly up to 3 months of acute pericarditis, as it helps in preventing recurrence in almost 25 to 30% of the cases. And incessant has been described as pericarditis lasting for more than 4 to 6 weeks, but less than 3 months, chronic being more than 3 months, and recurrent being that you have an interval-free period after the first episode, and then you again develop pericarditis within the 4 to 6 weeks interval. And as I said, the echo is the first class 1 indication. It is used routinely, particularly if a patient is going to present to the ER with chest pain, any EKG changes, echo is always going to be done. And again, the inflammatory markers are going to be done. Troponin is going to be done. And that brings to point a little subset of pericarditis, whether you have myopericarditis or perimyocarditis, depending on which one is more predominantly involved, and the therapeutic implication and the imaging implications. This is one where if you have troponin elevations and you're concerned about myocardial involvement, if you see any significant wall motion abnormality or patient has baseline, CMR may have a role here in delineating whether this is truly a pericarditis and myocarditis involvement as a composite picture. Again, here is the treatment that is now colchicine is, the dose here is the European dose. We have 0.6 milligram twice a day, again recommended for 3 months of duration to prevent recurrence. And this is the guideline. They've also identified certain features here which are like a fever, large effusion that would mandate them being a high risk and a risk of developing tamponade that they think should be treated more as an inpatient. And these are the new guidelines that have come across. So again, now, why is acute pericarditis important? Because we want to know that how many of this are going to go into recurrence, how can we prevent recurrence or incessant pericarditis, because there is an important role as this may lead to constrictive pericarditis. And as you can see that in idiopathic and presumed viral, the incidence of developing constriction is very low, less than 1%. It gets higher when you go into autoimmune diseases, immune-mediated diseases, or neoplastic etiologies, and very high for what we see in developing world, the bacterial and particularly tuberculosis or purulent pericarditis, which we don't see here. And so again, this statistics they have quoted is 15 to 30% of patients with idiopathic acute pericarditis who are not treated with colchicine will develop either recurrent or incessant disease, which puts them at risk for developing constriction later. So when is added imaging needed in acute pericarditis? Echo is going to be standard. So one is when you have failed treatment with NSAIDs or steroids with evolution towards recurrent or chronic pericarditis. Obviously, if there is any other things that is causing the pericarditis, such as penetrating injury, associated with any other disease process, whether it's neoplastic aortic dissection or pancreatitis, to name few. What would they offer in addition to the echo? Well, CMR will give you tissue characterization, and in particularly the late enhanced gadolinium is very helpful in defining inflamed pericardium. And again, it will also help us recognize very small organized effusion from pericardial thickening. CT will give you the effusate characteristics depending upon the Huntsville units. So if it's less than 20, it would be like a transudate, 20 to 60 would be exudative, and more than 60 would be sanguineous. But it is still not able to differentiate small effusion from thickening. So, and as I mentioned, this is CMR, and here in the first panel, and I don't know if you guys can see it, and I certainly find it hard to show from here, but between the two light, the whitish layer of epicardial fat, you will see a dark layer, and that is the pericardium. For me, it's easier to look at the gadolinium enhanced, and this is the pre-treatment with acute pericarditis. You can see the gadolinium enhancement here, very nice and bright and white, and decreased with post-treatment here. Whereas you look at this panel, this panel D here, and you see that on echo, you can just see a little bit of effusion here, which is an echolucent space, and which resolves here in post-treatment. So you can definitely appreciate how much the CMR and the late gadolinium enhancement adds here to this patient. Now, there has been a study done, a small study done at Cleveland that was looking at about 170 odd patients to see that in patients who have had acute pericarditis and increased inflammatory markers, what is the correlation of the late gadolinium enhancement on CMR with the inflammatory marker? And it was a modest correlation that was shown. So the question then is that when do you use this technique to supplement your clinical scenario? And I would think that it would make sense if patient is having recurrence or incessant pericarditis, it would make sense to get a CMR study and then look at it post-treatment and maybe even help guide the duration of treatment, because there are no current clear guidelines as to how long you should treat, except for the clinical that makes sense, that you treat for till patient is asymptomatic and the inflammatory markers come down. But should you be using CMR as a surrogate to look if the treatment has been adequate and then see if that correlates better with prevention of constriction? So that is something that's of interest. So as I mentioned again, if the clinical picture is clear cut, you don't need much investigation unless you have a complicated course. And here they even don't argue for echo, but I think everybody would end up getting an echo when they present with pleuritic chest pain and EKG changes. So then when CMR would be for a complex course of pericarditis, obviously if you have associated disease, CT would generally be preferred. And again, if you have a traumatic pericarditis, CT would perhaps be the first line of treatment in additional modality. So now going forward to pericardial effusions, which we see a lot in the echo lab here. And so what we defined as effusion on echo is going to be an echolucent area. It is going to be surrounding the cardiac silhouette. And how do you distinguish it from pleural and mediastinal collections? And what other normal structures can mimic pericardial effusions? So I'm just going to, this is your normal parasternal view, a little bit off axis perhaps, but you can see here, you see this pericardium as a bright echogenic area. You see this echolucent area, but it extends beyond the descending thoracic aorta, and it perhaps may represent a pleural effusion, which is better seen in this view here. And you can see that the pericardial effusion tracks the cardiac silhouette, ends before the descending thoracic aorta. This is a concomitant pleural effusion that is also present here. Short axis again, this is pleural effusion that tracks beyond the cardiac silhouette, and there is a little tiny pericardial effusion. This here, echolucent structure, would be the descending thoracic aorta. Again, as you can see, it goes away from the cardiac silhouette. So these are some of the things that we look for. And of course, one of the most common thing that we see is sometimes when, as a fellow reading in the echo lab, you see this and you wonder, what is this? Knowing what is normal is very important so you can define what is abnormal. And this would be a rather prominent epicardial fat pad. You can see it here and you can see it here. And you can see your pericardium very well if I'm pointing here. Oh gosh, I'm not very good at pointing. There. So this is something that you would see a patient who is post-CABG. You have a post-CABG echo, and you see an echolucent space. You see a classic pericardial effusion around the anterior and posterior. What you're looking for to see if is there any hemodynamic effect on the RV in this view, and you don't see it. And here's the short axis, again the same. So again, in this view, you can see what you would look for is respiratory variation to say whether there's increase in intrapericardial pressures, and you can see that with with respiration there is variation. On the left side, you want variation of more than 25%. On the right, more than 40% for it to be considered significant. And okay. This is very nice, classic. I think anyone who sees this will know what we are looking at. And here you're seeing beautifully the invagination of, or the collapse of the RV with an anterior pericardial effusion. Beautifully seen here on the M mode, the RV diastolic collapse. Frame rate is much higher for the M mode, so sometimes if it is not as obvious as this and it is very subtle, you can use M mode to pick this up. Again, this is being one of the right outflow tract being the most vulnerable area, is also an area that you want to look at, even if RV looks like it is expanding well, to see if there is any hemodynamic significance. Again, the MOD here and here. So multiple views to show that how nicely the RV has diastolic collapse, and this is, of course, tamponade with good clinical correlation required. I want you also to see how you may not necessarily have the obvious collapse, but this should also raise a red flag. This is a post-op patient, again, post-cardiac surgery. And here you don't see an obvious RV collapse, but you are seeing something here. And what you're seeing here is that RV looks like it is just constantly being compressed. There is no obvious systolic expansion. And what you're concerned here is what is overlaying the RV here. And you can see it even in this view, that there is the RV-OT also, while there is no obvious collapse, it seems to be, as we would say, struggling to stand up. And in this view, you can see that there is some echogenic material around the heart. You see nothing very convincing. Sorry, let me go back. Nothing very convincing here by Doppler. But again, this view is very concerning. If you see something like this, you have to be very concerned that this is a very hemodynamically significant collection in the pericardial space. And this is what, when they gave contrast, it lit up outside. This is a hematoma, and obviously the patient had to be taken to the OR for evacuation. So again, beautiful use of contrast. Even if you didn't have it, it would have been enough to say there was a hematoma overlying the RV. See this. So again, now this was a very interesting case. This is a 52-year-old gentleman who had had his aortic valve replaced. He had small effusion post-op, and he was being treated medically. He comes in after a couple of weeks. He has it done sometime in early July, mid-July. He comes in with shortness of breath, fevers, and tachycardia, and his blood pressure was elevated on admission. TEA was done to rule out any endocarditis of the prosthetic valve, and this was his TEA that was done on admission. And there is some echolucency, but nothing really jumps out that says that there is a vegetation. Maybe there was some concern that is there something here, but nothing obvious. Blood cultures are positive for staph, and while he is being treated, he goes into cardiogenic shock, collapse, and immediate echo was done in the FICU, and if anybody cares to take it. Who's the echo fellow? Nadia, you want to take it? So this was done, and I want you to tell me what you're seeing here. So, So what is concerning is what is this here, and obviously this is the TE that was done. They dropped in a probe and they see this. So you can see that. So this looks very much like a large hematoma that has developed acutely. And this was clinically something that was very interesting. They take him to the OR, they evacuated. What they found was that the patient, a couple of sutures had become undone where the bioprosthesis was lodged, and he really bled into the pericardium. The question was there he was staph positive, but on the first TE, we did not see anything that we could have called as vegetation. He gets evacuated. This is a follow-up TE that was done. And as you can see, beautiful results and beautiful recovery for the patient. So often things can be dynamic and change. One of the things that is very important to realize with tamponade or effusions is the interplay of the intracardiac pressures. So this is a lady who was admitted with shortness of breath, tachycardia, hypotension, with known history of pulmonary hypertension. And you see, sorry. And this is honestly something that is very hard to pick up by eye, unless you're very skilled like as you get years of experience under your belt. But you can see there is something funny about the motion of the wall here, which is better picked up by M mode. And what you're seeing here is the posterior LV wall is collapsing in diastole. And there is a collection locally here. You can see RV is very large and perhaps not very has significant depression of its function. This was the apical views, and then we did the Dopplers. And you can see there is a significant respiratory variation. What is important is the TR jet. You can see it's almost up to 4. So this is a place where patient has a very high, has significant pulmonary hypertension and has become now hypotensive, tachycardic, all of which could be related to the pulmonary hypertension, but in this case was because of the LV diastolic collapse related to the loculated effusion around the LV. So again, that was just to show the interplay of the cardiac pressures. Again, this was a patient who presented, mid-60s gentleman who presented with chest pain, which was it felt like this could be acute MI. Echo was done, and what was surprising to see here was that there is an anterior collection and the RV is collapsing. And you know, whenever you have something like this and a chest pain, you want to make sure you look at the aortic root. It looks a little dilated, but honestly, on this view, I did not see any obvious concern for a dissection in this view. Again, just to show how the RV is coming in here. And there was respiratory variation, but not the best Doppler. This is real scenario, so you see what you get, and they put some Doppler. And honestly, on this Doppler in suprasternal notch, there was nothing again concerning. However, and I'm hiding this, it is, I don't know if you can appreciate it on this larger screen, there is a dissection flap here. And so the concern was this was aortic dissection with an anterior effusion with RV collapse. Obviously, this has grave implications all around. Patient had been taken to OR. I think they had CT diagnosis too. So in most cases of pericardial tamponade, transthoracic echo in FICUT is sufficient imaging modality, and no additional modality is required. And again, there has been in ESC, they have raised the issue of, so if you have a large pericardial effusion, obviously you're going to go in for pericardiocentesis. But the question is, if it's small, you're not going to do anything. Does every moderate to large pericardial effusion need to be tapped or to be treated? And that is a question that has not yet been answered. So do you leave it alone is the question. And now moving on to constriction. So constrictive pericarditis is a thickening of the pericardium that restricts the filling. So you have a thickened rigid pericardium, you have fixed pericardial volume. There is loss of the transmission of the changes in the intrathoracic pressure with respiration to the rigid pericardium and in turn to cardiac chambers that gives the pathognomic respiratory variations that we see on both echo and on cardiac MRI. We know the increased atrial equalization of end-diastolic, the dip and plateau from cath. And again, the causes remain the same. The viral infections, surgery, radiation being a big one. However, with now with modern radiation for lymphoma and other cancers where you lose lesser dose, lesser frequency, you're not seeing as much. But the causes are pretty much similar to what you had seen earlier. And the symptoms, patients can present with fatigue, shortness of breath, marked right-sided heart failure symptoms of venous congestion, and the classic Kussmaul sign, JVP elevation, and the pericardial knock. As I mentioned, it is rigid and does not transmit, and that is what is important. And I think for fellows, it's important to understand what causes the inspiratory decline in the left-sided transmitral gradients that we see. What happens is that during inspiration, because there is loss of this transmission of the intrathoracic pressure, there is no decline in the left atrial or the end-diastolic LV pressures with inspiration. So there is a loss of gradient from the pulmonary veins to the left atrium, and which is also seen across the transmitral, and therefore you have decrease in your velocities. And the reciprocal is seen on the right side because now you have a fixed volume, so right side can accept more. And because of this physiologic process that occurs, you have all the Doppler data that we get, whether it's transmitral, tricuspid, hepatic veins, the pulmonary veins, that give the pathognomic picture of the constriction and helps us differentiate constriction from restrictive cardiomyopathy. However, it is to be noted that just because you don't have respiratory variation does not mean you don't have constriction, because if you have very high LV filling pressures, and you have very high preload, you're not going to exhibit the variation, A. And so you can do some maneuvers to decrease the preload and look for the variations. And secondly, if you have it, does not mean you have constrictions, because there are other pathologies that can cause respiratory variation, which are COPD, RV infarct, PE, and even acute respiratory distress. So here is a case where patient is admitted with shortness of breath, elevated right-sided pressures, venous congestion, and even on echo, you can appreciate that there is significant what looks like thickening of the pericardium. And there is a suggestion of there is a diastolic septal bounce here, and there is definitely respiratory variation. And as I mentioned that in real life, you can see the IVC plethora, but again, no respirometer was done in this particular patient. This patient also had additional imaging done, and you can see the pericardium light up here, and you can see it in this modality as a white thickening. And so I believe constriction is one where additional imaging definitely has a role, particularly if you're planning a intervention. CT would be the way to go, because CT, what it does is it gives you can define calcifications very well. You can define the entire geography of the pericardium, which would be very important when you have to resect the pericardium, and because pericardiectomy being the definitive treatment. However, constrictive pericarditis has a high mortality with pericardiectomy. So selection of patient has to be very careful. One must realize that even in acute pericarditis, you have what is called effusive constrictive physiology. You will have the diastolic septal bounce. You will have features of constriction. But if you intervene at that point, it would not actually be required. You treat the patient with NSAIDs aggressively and follow the patient. The question is, how long do you follow the patient? What signs do you look for? You look for signs of constriction down to 6 months. And there have been anecdotal reports in literature when at 6 months, 12 months periods, patients are symptomatic or have signs of constriction, then you go ahead and intervene with pericardiectomy, because that is the definitive treatment. On the other side, not every constrictive pericarditis has to be intervened upon, even in the final stages, because it has a very high operative morbidity in 6 to 12% range. So there have been signs where they look actually for the score similar to the cirrhosis of liver. So if you have hypoalbuminemia, if your PT is elevated, if you have ascites that is not responding to medical therapy, you have low sodium, all these are bad prognostic features. Acute renal failure or renal failure, bad prognostic feature. These are the patients who are not going to do well even with pericardiectomy. So the timing is important, the selection of patient is important as far as pericardiectomy goes. And interestingly, calcification has not proved to be a predictor of a poor outcome. So you could have a heavily calcified pericardium, but that's not a poor predictor of operative outcome. Okay, I'm trying to remember. Okay, and so again, you can have, you don't need to have a constriction, the entire pericardium involved. You can have segments of pericardium involved. You can have even hematoma causing constriction, as you was seen in this case. There is a subtle septal bounce. You see a large hematoma here. And this patient, you can probably appreciate a little bit of diastolic septal bounce here, and you have variation. So this patient had a localized collection of hematoma that was causing constriction. So diagnosis of constriction remains challenging. There's no single diagnostic approach, and every strategy of diagnosing has to be tailored to the patient, his presentation, his comorbidities, and what you plan to do with the patient. However, echo it is intuitive that he is going to get an echo, and it does help rule out a lot of things and rule in a lot of things. So you can assess the RV, LV function, you can assess for severe pulmonary hypertension, you can look for left-sided diagnosis that may have been missed, and then you can show the exaggerated ventricular interdependence very well on echo in most cases. So it is a very beautiful diagnostic tool. However, in most cases, it will have to be supplemented by additional imaging if you're planning an intervention. Septal bounce is we have talked about. However, it's not the most sensitive, but it is very specific. IVC plethora has found to be more sensitive, though less specific. And there is this nice case we had of a young man who was presented with shortness of breath. We do an echo on him. And on this view, we feel there is a suggestion of septal bounce. Again, seen here. Again, this is not the best view. There is some respiratory variation. And I want you to focus on his IVC. It collapses beautifully. This is a gentleman who had cystic fibrosis. And his symptoms were, and the bounce that we were seeing was not actually because of constriction from pericarditis, but because of his cystic fibrosis. So you have to be careful in the history of the patient is very important. What is the role of additional imaging in constrictive pericarditis? So obviously, I think we all agree that if it is very convincing diagnosis, you are still going to do additional imaging if you're going to plan surgery. CT is going to be done to define the exact anatomy of the pericardial sac, the calcifications, to help the surgeons deal with the surgery. And if it is, you cannot rule out constriction, additional imaging with MRI and CT will also be done at that point. Now, MRI obviously has an added advantage over CT that you can do the same hemodynamic functional data that an echo gives you, you can get from an MRI. CT you can get, but you would be exposing a patient to a lot more radiation, and therefore you're not going to do it. So the recommendations, again, by the European Society of Cardiology are, echo, chest X-ray, and CT and MRI indicated a second level of imaging techniques to assess the calcification, thickness, and extension of pericardial involvement, and cardiac cath too. So as I mentioned, I'll let Faisal is Haran. He's going to go into all this, and I will leave it for him. A word of caution that, we all look for thickening for constriction, but sometimes you don't see it. There was a study done that showed that at least 28% of surgically proven constrictive pericarditis cases had a normal pericardial thickness on the CT, and 18% had normal thickness on surgical biopsy. So again, we look for surrogates of inflammation and sac thickening, but sometimes you don't need it. It's how the pericardium behaves in terms of its relaxing capacity compliance that is of very great importance. And obviously that is where the clinical presentation of the patient, the hemodynamic data that we get from echo and MR are very important.
A great talk by Gopi, and really I think she covered really all the very important aspects of this disease. My job is really to maybe reiterate one more time some of the things she has mentioned, and then also to show, at least specifically for CT-CMR, some of the features that we look for that suggest these different disease processes. And I'll move quickly. So as discussed, pericardial disease is really a broad spectrum of diseases, and I'm just focused on maybe a few of these to discuss how we can use advanced imaging. Echo, by far and away, is the number one modality that should be used. It can, in vast majority of cases, answer the clinical question and as well as make the appropriate diagnosis. However, yes, I mean, there are cases where it can be difficult, and not only when information is non-diagnostic, but if patient imaging makes the situation a little bit difficult. So cardiac CT and MR are new kids on the block, new tools that we can have to evaluate the pericardium and its anatomy. These are fantastic tools. They both have large field of views, high spatial and resolution to see the entire chest, to be able to see actually all the different components of in the thorax. And to some degree, with CMR, we have the ability to also do functional imaging, which is the strength of echo. So one of the disease processes I'll discuss is acute pericarditis. We heard about it from Gopi. This is just maybe one of the same slides she used. But one of the things I decided to do in this talk was I will show you some of the features with advanced imaging of these different modalities. But the question is when to get these advanced tests. So vast majority of cases, of course, you have the right clinical situation, you got the right EKG, the right symptoms, the right cardiac biomarkers, and an echo with a small pericardial effusion, the diagnosis is pretty much made for you. But in many cases, yes, if the echo is completely normal, which vast majority of cases it can be, the situation may not be as clear. Really, where you should consider advanced imaging are in cases where the patient has recurrent episodes of pericarditis, or where there's high-risk features involved. And really high-risk features involved meaning, does this patient have persistent high fevers? Are you seeing evidence of wall motion abnormalities on the echo, which may also explain a myocardial process as well? Is there evidence of tamponade, et cetera, et cetera. So or when the patient is really failing to respond to the medical therapy that you have prescribed. So these would be situations where you may consider advanced imaging. Now, in this disease process, CT more than is unnecessary, really may not play any role, but I will show you some features where you to go ahead and obtain that test. Really, the test here would be with CMR, and because of its ability for tissue characterization, and specifically looking for inflammation of the pericardium. So, and this is just hopefully reiterating a lot of those points which I just mentioned as to when to consider advanced imaging in acute pericarditis. I bring this slide first, not because we should get CT, but only to show, with CT and CMR, you can really see the pericardium very, very nicely. It's this thin, very curvilinear structure that's running anteriorly over the RV. You really see it well over the right ventricle, and sometimes not so well over the lateral and inferior borders of the heart. And the reason is because there's less fat around laterally and inferiorly, and you really don't have the difference in tissue attenuation to be able to see the pericardium. You can see you don't need a contrast CT to be able to see the pericardium. You can do it without contrast. So what would you see in acute pericarditis? Really, you would be looking for any thickening of the pericardium or a pericardial effusion. And so here's an example on the right-hand side, just a simple plain pericardial effusion. We can we have some ability by checking the Hounsfield units to determine whether these are transudates or exudative process. And on the right-hand side is an image where you can actually compare a much thicker pericardium compared to that normal thin curvilinear image I showed you in the screen before, showing you what a thickened pericardium would look like. If you look really closely and if it projects well, you can in fact, although this is the strength of CMR, you can in fact maybe agree with me that you may see some contrast uptake in the pericardium on these images. And that would be, again, our surrogate of that there's probably some inflammatory process ongoing here. Here is what the pericardium looks like with CMR. Again, really no different from what we saw from CT, this very thin structure. We use specific sequence. It's called a T1 weighted spin echo sequence to be able to see the pericardium. And remember, this is a modality which is without any radiation. And in this particular case, without any need for iodinated contrast. Again, with CMR as well, we can evaluate pericardial effusions. Where it is located. A lot of these effusions can be loculated, but also kind of based on its appearance in different sequences, help determine what the nature of the pericardial effusion, and more on that coming up. But really, the strength of CMR when it comes to acute myocarditis is, again, the ability to see active inflammation. Active inflammation here would be, once you have given gadolinium, to see gadolinium uptake in the thickened pericardium. And the top set of images are just what we call our FISP images, or our regular echo-equivalent anatomical images, whereas at the bottom, that white rim that you see around the heart is what we call delayed hyperenhancement of the pericardium. And I'll have some few slides upon that coming up in our slides ahead. But when delayed hyperenhancement of the pericardium has been histologically shown as to be proof of an inflammatory process, an active inflammatory process in the pericardium. Okay, so what about pericardial effusions? That's also very common. When should you consider advanced imaging for pericardial effusions? And as Gopi has probably mentioned, really, echo frequently can see effusions, but you really want to consider it if you have a complex effusion, if it's loculated, whether there's a question whether there's clot present. Whenever localization and quantification are important, this can be very helpful. Sometimes we all know it can be very difficult by echo, teasing out between a pericardial effusion and a pleural effusion. This will really not be an issue with the advanced imaging techniques. And I'm just going to go into that. So here's a case. This was a case of a pericardial effusion, but the cause here you can see on the bottom right-hand side, bottom sides of the screen, was really malignancy that was infiltrating the heart. So these are large field of view imaging techniques, so we're not just restricted to the pericardial effusion itself, but we can actually hunt for a cause, and in this particular case, a malignancy. And here is just an example of a CT in a patient who had a thoracotomy, wasn't doing well postoperatively, was difficult to see, maybe because of surgical bandages and things like that with echo. But when you're able to see the entire chest, it became very obvious what the problem was with this patient. This is just an example of a loculated pericardial effusion seen by cardiac MRI. Again, very, very similar images. If this movie wants to play, yes. Maybe running a little bit slow. Cannot play media. Okay. So, but I would have showed you one of the markers. I would have shown you ventricular coupling and showing you that this was a hemodynamically significant effusion. So when it comes to tissue characterization, this is not the strength of CT, but we do check the Hounsfield units of the effusions. We can give you an idea of what we think is in there. Anything between 0 and 25 Hounsfield unit, anything close to water is generally transudative, whereas an effusion that has a lot of protein tends to have a Hounsfield unit greater than 25. Acute blood generally has a Hounsfield unit of greater than 60. And these are just some numbers to remember the way we use CT. CMR is a little bit different. There are some, based on their how it appears on T1. Exudates tend to have be brighter on T1, and how an effusion behaves on different sequences. We can help figure out whether what we're seeing is an effusion, is it thickening, is it fat, and then also the nature of the effusion we're seeing, the way it behaves when we perform different sequences. So, and when it comes to cardiac tamponade, really, CT and CMR are not the first-line tests. you shouldn't confirm tamponade with advanced imaging technique. Rather, as imagers, I have to be aware of secondary features that I see on patients who may come to the lab with, undefined or tamponade. So, what are some signs that I would look for? And these are really, if you just remember, the basic pathophysiology of tamponade, you have poor forward output and you have elevated filling pressures. So, these are just some classic 2D morphological imaging findings that we would see both by CT and CMR. You would see a large effusion. You may see compression of the heart, what we call this flattened heart sign. You may see abnormal bowing of the septum, indicating now you have ventricular coupling and dissociation of the intrathoracic and intracardiac pressures. You have elevated systemic pressures, and therefore, the IVC, azygous vein, may look juicy, as well as the hepatic veins. And if you give contrast, you may see a lot of reflux of contrast into the hepatic circulation with very dilated IVC and hepatic veins. So these would be tip-offs to us that, whatever we're seeing is this effusion we're seeing is hemodynamically significant and would alert us to, notify the patient immediately. Wow. Okay, so along the lines with CMR, we actually have the ability, with real-time imaging to actually be able to see this dissociation between intrathoracic and intrapericardial pressures, and specific things we would look for are, are we seeing IVC plethora? Are we seeing an IVC that doesn't collapse? With respiration, with real-time imaging, we can actually watch the heart behave inside the pericardial sac and watch, what's going on. Do you see the heart swinging in the pericardial effusion? And that would be a marker of electrical alternance that you would see, or the cardiac oscillations that you would see. We can actually see, as the patient inspires and expires, how the intraventricular septum behaves with the ventricular coupling. Now moving on to constrictive pericarditis, Gopi went along and told you all some very important echo findings of constrictive pericarditis. But, as she had very well mentioned as well, unfortunately, sometimes the diagnosis is not so easy with one test alone. And really, it may require advanced imaging, and it really may even require a left and right heart catheterization after that. But some conditions where it can get tricky are in situations such as atrial fibrillation, mixed connective and restrictive heart disease, or in patients who may have markedly elevated LA pressures where you kind of lose the respiratory variation changes. So how can advanced imaging help us? Again, really the workhorse for this is going to be cardiac MRI. Cardiac CT has a role, and we'll elucidate that in the next upcoming slides. But really, CT is an anatomical technique. So whenever you need to know anatomy, it can be very, very helpful. So if, like Gopi had said, if you want to see if the pericardium is thickened, great test. You want to know how calcified it is, where the calcium is, great test. But it may not necessarily provide you any whether there's any hemodynamic compromise to the ventricle or what the hemodynamic effect is to the ventricle. And here CMR can be very, very helpful. So there's many tables out there. This is just another one of those tables. Concept was the same as Gopi had said, that when should you consider these advanced imaging tests, specifically CMR? Well, if you have a typical echo and you've got all the markers of inflammation elevated, well, you probably don't need any test. But if patient isn't responding to anti-inflammatory therapy, or they're having recurrent bouts, or the diagnosis is not sure, then you definitely consider these other tests to help you make a diagnosis. So this is kind of what I went over. CT is great for anatomy. We have a lot of 2D morphology, and so is CMR. CMR adds the additional advantage of having physiology and tissue characterization with delayed hyperenhancement. There are a lot of 2D anatomical features that suggest to us constrictive pericarditis. A lot of these, again, were mentioned by Gopi. Specific for the CT and CMR is really, seeing, this heart being compressed. Usually it's compressed in the basal and mid segments, so you'll see the ventricle kind of take this tubular morphology. Ventricles will tend to be small. You may see, flattening or inversion of the septum, and then you look for secondary signs of elevated systemic venous pressures. And I will show you pictures that probably will not play, but we'll show you pictures of that. Now, this was just a slide that, we all, which test is most sensitive, which test is more specific. I try to remember the specific ones. So specific ones for constriction are, if you do see pericardial, in this study, if you see pericardial thickening greater than 4, that's pretty specific. That's very specific. If you saw abnormal septal diastolic motion, that's specific. As well as having a preserved, the pulsus annulus paradoxus, or a preserved E prime at the septum greater than 8 is also very specific. So here are some features by CT. Again, you're looking for anatomy. Here you can see a very markedly thick circumferential thickening of the pericardium on the left. An end stage of this thickening would be calcification, which you see on the right. And you can kind of just see how the heart, you can see where, there's a filling occurs early in diastole, and you can imagine once it hits this calcium, once the heart is expanded to a certain point, this calcium's not going to let this heart fill any further. And once that happens, filling pressures will be high, and then we have a whole host of signs, some of which I've mentioned with the tamponade portion of it, but other signs suggesting elevated filling pressures. CT, I put this in there because, it's there in the literature, and I'm hoping to get a slide of my own one day, but this is what delayed, if I were to see it, this is what delayed hyperenhancement of the pericardium would look like, where you can see there is definitely some uptake of contrast within the thickened pericardium. But really CT's role, I think, would be, is in patients, who may have those who are headed to the operating room, where you really need to know anatomy, those who are heading to the operating room with prior sternotomy, where you may have to know where vein grafts are, where the right ventricle is in relation to the sternum, where the lima is running. These are very important. And it may be in cases where the patient has injury from radiation, because as you know, radiation is a pan-cardiomyopathy and pan injury to all the heart muscle. So it can involve valves, it can involve the muscle, it can involve the chest, the lungs. So you may need a technique that sees everything. When it comes to CMR, this is just a slide showing you in our Turbo 1 spin echoes how we measure pericardial thickness. This is kind of what it would look like on our workstations. I would take this up, zoom it up, and take a caliper and actually measure this, and in our reports hopefully try to tell where exactly this pericardium is thickened. Note that it doesn't have to be circumferential. These can be localized in certain certain locations and still cause a constrictive physiology. Okay, and here are some features that we look for. If you can see on the right-hand side, this ventricle looks conical shaped. You can see the atria are markedly enlarged, suggesting that LAP and RAP are high. Similar to echo, you can have the diastolic shudder of the septum, or in some cases maybe a frank septal bounce, all indicating ventricular coupling, all the result of the basic cause of constrictive pericarditis, which is the dissociation of your intrathoracic from your intracardiac pressures. We would see a lot of the same features, and all our studies for constrictive pericarditis, we evaluate this. We would look at the IVC, the hepatic veins. We would assess for respiratory variation as the patient was breathing. We can consider myocardial tagging if we had to, where you would see that the pericardium and the myocardium are moving together and not independent of each other. we can see signs of ventricular coupling. And this is just a great example of that. If you can imagine here, this is real-time imaging. As the patient inspires, remember filling increases on the there's less of a gradient on the left side, more of a gradient on the right side. So there's a more inflow on the right side as the patient inspires. The increase, because with the increase in flow on the right side, and there's a shift of the septum towards the left. And this process is reversed with expiration. So this is just an example of that. There are sequences now which are real-time phase contrast CMR, which again, phase contrast CMR is our echo Doppler, and we can actually, look at mitral and tricuspid inflow velocities, and similar to echo, try to diagnose respiratory variation across those AV valves. CMR can be helpful, again, very helpful, remember, because it has... These are velocities. These are velocities.
Through the mitral and tricuspid?
Yes, creating a slice location at either the mitral inflow and tricuspid inflow, and looking at your flow back, coming in and outside the ventricle. In cases where difficult cases where there may be a concern where the patient has a concomitant restrictive cardiomyopathy, such as, for example, amyloid, or patients with radiation. Here, looking for delayed hyperenhancement in the ventricle may be of use as well. And then finally, where I think it's very helpful in constrictive pericarditis is, obviously, if you have a CAT scan where you have diffuse calcification, well, this is burnt out disease. Probably this patient does not have any active inflammation ongoing anymore, and probably this patient is headed to surgery. But in a lot of cases where symptom onset may be more recent, you don't see extensive calcification, it can be very helpful, as Dr. Q was saying, to get a CMR. And this is just an example here of a case of constrictive pericarditis where you can see the pericardium in this bottom sets of delayed hyperenhancement images, where you just see this diffuse global uptake, this whiteness. That pericardium is all white. All the white that you see is a thickened pericardium taking up contrast. And what this means is active inflammation. And this is this same patient that was then treated with 6 months of anti-inflammatories. And, I can show you the before and after, but you can see the diffuse rim of hyperenhancement here. And as we go to the next slide, you can see, a lot of this is fat, but if you look in the short axis sequences, you don't see that rim of whiteness anymore. So it can be very helpful in telling you how long to treat your patients, especially those patients who may not be initially responding. They have taken patients who have had diagnosed active constrictive pericarditis. They've done histology on the pericardium when they went to the OR, and then tried to correlate their findings, what they saw with CMR. And in those patients who had CMR positive gadolinium, those pericardiums showed signs of neorevascularization and fibroblast uptake, which really are all markers of active inflammatory process. And this was just a small paper saying in 29 patients where they were able to document that in patients with they are a subset of patients with constrictive pericarditis who have resolution of their symptoms with anti-inflammatory therapy. So pericardial masses, if you want, I can continue. There's, there are different masses. Dr. Chang and I will be giving grand rounds on pericardial disease, so we'll hit a lot of these, maybe in some, show some exciting cases. But both these advanced imaging techniques are really crucial to making the diagnoses. CMR is very helpful because of its tissue characteristics. Okay, and this is just an example. Okay, I shouldn't have done that. These are just, this is just an example based on tissue characteristics of the intrinsic tissue characteristics of a substance. We can try to figure out what an abnormality is. So here you see this is a large cystic structure close to the apex of the heart. It is dark on T1, bright on T2. Okay, this didn't play, but it did not take up, there was no evidence of first pass perfusion, and on delayed hyperenhancement, there really was no evidence of contrast uptake. This would be very consistent with a pericardial cyst. Same thing we can do with CT. It's pericardial cysts are most commonly at the right costophrenic angle. They tend to be benign, well circumscribed. We can put a region of interest, determine a Hounsfield unit. Most of the time they have tissue intensities close to water. And then, of course, malignant processes are very important. These are just some images with CMR. You can see here how, in this one mass on the right-hand side, how it is invaded and occupied the entire right intrapericardial space anteriorly. And here you can actually see a mass that's invaded through the heart with an associated pericardial effusion. These are just some points when to consider advanced imaging, a lot of which I've hit on. These are slides that express the same.
So, a couple of things. One is, this was great. If we cut down some of the masses at the echo part, it would be a great talk for the multi-modality. I think we should put him on, because that's a great topic. Couple of questions, scenarios. In our environment, we have both tests. So, quick scenarios. We suspect malignant effusion by the clinical scenario, and maybe the fluid and everything else. CT or CMR? Quick. Don't give me
CMR.
a dissertation. Which one did you go for?
CMR.
Huh?
I'll go for CMR.
Why not CT since you see a lot of the lung and you characterize the lung, malignancy?
Okay. This is where this question becomes a little difficult. It depends a lot of patient factors. Okay.
Give me one.
I'll tell you what. CMR by inherently is a longer test. So it will take an hour. If you need a quick answer, go with CT. If you need, if you're interested in what else, this is a malignant mass, you're looking for a malignant mass. If you need to know tissue characteristics, especially if it's in the heart, then CMR will assess those things. Yes, it's true. If you don't know where the
scenario, it's belly cancer, the patient has a TAP, is hemorrhagic. You may want to have more data.
However, if you're looking for either a primary or involvement of other organs, I would go for a CT.
Yeah, that's what I'm thinking too. I'm thinking CT just because, not because of the heart, because everything else you may get out of it.
I think CT is a very good test.
Another scenario, crappy kidneys, okay? The crappy kidney syndrome. Let's say we've done the echo, now we are in that phase where we're thinking we may need some help. Okay, CMR without contrast or CT without contrast?
And what is the disease entity you're concerned about?
Well, patient has pericarditis, and obviously it has reached a point where you want an advanced imaging. So we passed that part already. But the creatinine is 3. So do you go with CT without contrast or CMR without contrast?
I will go with CMR, and the reason is you can see we for functional imaging, constrictive physiology, we'll identify with without contrast.
But we may have done that with echo already.
But you wanted more information.
If you're looking for thickness of the pericardium, it's the cheapest test because it's going to be without contrast. CT without contrast is going to be the cheapest test.
Well, I was hoping he was trying to say
Dr. Q, no, we can see. We'll see thickening. We'll see thickening. We'll see thickening and calcium. Yeah. Yes. Yes.
Particularly if there's fluid, I mean that definitely is.
That's where it becomes difficult, Dr. Z, because if you have associated fluid will have a very similar Hounsfield unit as to your pericardium. So a lot of times I'll see something and I won't know is it thickened pericardium or is it fluid. And that has happened many times.
And oftentimes they have fluid. That's my point.
Yes.
And so, because you don't want to get false positive, say, oh yes, I see him 4 or 5 millimeters big. It could be fluid or it could be bigger.
Yeah. Like a situation like effusive constrictive physiology, effusive constrictive pericarditis, you want something where you know what's pericardium and what's fluid.
So in that scenario, with the bad creatinine, you probably would prefer a CMR.
Yes, we don't need to give contrast for other than for the delayed hyperenhancement, you don't need contrast.
Would you be able to separate the effusion and the fluid?
Very easily, because of different tissue characteristics.